Hi, everyone. Welcome to STAT's virtual event, Can Tech Fix Primary Care, sponsored by Nuance. Thanks to you all for joining us. I'm Bob Herman, the Business of Healthcare reporter here at STAT. And before we get started, a few quick housekeeping items. At the bottom of your screen, you should see several icons. Use the chat feature to chat amongst yourselves or to send a message directly to the STAT team. Please do not put your questions for us in that chat. If you do have a question that you would like to ask us during the event, Fix Primary Care, please use the Q&A feature to type your question and we will try to answer it live. In the Q&A window, you should also be able to see questions that other attendees have asked and upvote the questions you would like to see answered most. We'll be taking questions throughout the chat, so please don't wait until the end to submit. This is part of what makes these events engaging and fun. We want to hear from you. Thanks again for being here. Before we get started, I'd like to welcome Dr. Jared Pello, Chief Medical Information Officer at Nuance, for a sponsored introduction of today's event. Please note that these remarks have been pre-recorded.
Hi, everybody. My name is Jared Pello. I'm an emergency medicine physician, and I am the Chief Clinical Product Officer at Nuance over the Dragon Ambient Experience product. At Nuance, our goal is to really turn the chair around for clinicians. And what we mean by that is that instead of clinicians being focused on the administrative task of documentation, that they can focus on their patients, what their patients came to be seen for. Now, we believe that machine learning and AI is what is going to help solve many of our ills in healthcare. And in many of those ills, many of those obstacles in healthcare, just to name a few, are that there are increasing burdens on our time, increasing operational inefficiencies. We're asked to do more with less. There is an increase of burnout across all clinicians, not just physicians, but every clinician in the health system is feeling more and more burned out. And for myself, I had been practicing medicine back in 2013, been out of residency for a few years, working in a busy level 1 trauma center. And I grabbed my partner one day and I asked him, he was the happiest guy in our group. And I said, Andy, how do you stay so happy? How do you love your job? And he said, Jared, every day that I have off, I dread coming back to work. So I learned two things that day. Don't ask Andy for a pep talk because he's terrible at them. But number two, he said, those who seem happiest in healthcare are those who are working to make healthcare better. And one of the reasons I love talking to groups like this, and I'm really grateful to do this introduction, is because if you're here, if you're spending time watching this, then most likely you're one of those people working and wanting to make healthcare better. So we believe that we can solve that clinician burnout by allowing the clinician to get back to doing what they went into medicine for. And as a clinician myself, I know that I went into medicine. Well, actually, my thing was I love to serve others and I love science. I love medicine and I felt really passionate about it. But when I found myself not spending time on that, it was painful. And that's what clinicians face every single day. And then I would say the other thing that really bothered me was I knew my patients weren't getting the experience they wanted. As a patient myself, when I go see my physician, if they got their head down, and I actually just went a couple of weeks ago, and he had his head down typing at the computer, not making eye contact with me, not able to watch my nonverbal communication. And at Nuance, we've developed something called Dragon Ambient Experience. And Dragon Ambient Experience is an AI tool that records the doctor and the patient talking, and then takes that recording, synthesizes it into clean, diarized transcripts. What that means is the doctor has a transcript, the patient has a transcript, anybody else in the room has transcripts. And then we use a large transformer model, neural network AI, and it does natural language generation, writing the note for the doctor. And this saves a doctor about 7 minutes on every patient visit, which has been truly remarkable to see. And because of that, we see a 70% decrease in feelings of burnout from clinicians. 9 out of 10 say they would recommend this product to others. 80% believe that the documentation is higher quality than they would do themselves. And patients, this is my favorite statistic, 80% say that their physicians are more focused on them, more conversational, and spending less time on computers. Now, we are really at the beginning of this journey. And why I think that this event is going to be so inspirational, so exciting for everybody to learn about, is that we're on the beginning of this AI journey. And I'm a little embarrassed to say that back when I started my startup in 2014, I was on a podcast and I was predicting the end of medical doctors. I believed that Watson was going to learn medicine and that we would merely be technicians. I no longer believe that. I believe that AI will extend both our intelligence and our compassion, allow us to connect with patients in new ways, and allow us to really heal. And we're at the beginning of this. And I think that what you're going to experience over the next hour as you listen to these experts is going to be really fascinating and hopefully give you all ideas on ways to tackle the problems ahead of us. So to end, I would just say thank you so much for taking time to come to this event. Thank you for being interested in making healthcare better. And I'll sign off and let the experts take over. Thank you.
Thank you to Dr. Pello for the introduction. And here to join me for today's discussion, please welcome Owen Tripp, co-founder and CEO of Included Health. Thanks for joining us today, Owen.
Nice to be here, Bob. Good to see you.
Likewise. Well, maybe just to start, Owen, I think it'd be helpful just to have people understand, a little bit more about your story, how you got to Included. Obviously, you were at the predecessor company, which was Grand Rounds, and then it merged with Doctor on Demand to create Included. So tell us a little bit about that journey, how Included came to be, and how Included has changed over the past couple of years.
Yeah, for sure. So we started Grand Rounds in 2011 with a pretty simple problem in mind. And it's a problem that persists and gives us a lot of energy today, although hopefully in our discussion, you'll hear some evidence that we've made some real progress on it. And that problem was that the difference between getting the healthcare outcome that you want and need in this country and the healthcare outcome that most people actually get is one of information and expertise and how we connect those things. So let me just sort of concretize this for you a little bit. Grand Rounds really started out identifying that when used properly, the American healthcare system is the best system in the country. We have fabulous medicines, technology, science, educational institutions to support the science platforms, but we don't use it very well. In fact, we know the data that it takes about 17 years for a new evidence-based therapy or approach to a complex disease to make its way to the majority of clinicians who could be treating that disease and become part of the standard way that they treat it. So think about that, 17 years between the fundamental discovery in science and paper to widely practiced. And we need to shorten that loop. And we need to shorten that loop for a lot of reasons, because where you get care and how you get care may just be an accident of where you happen to live and what you get access to. And so let me sort of take that story and then bring you to present, because I think that is instructive, not just about what my company's been up to, but what we've seen in the United States is what is truly required for the whole solution. So we started Grand Rounds to democratize expert opinions and access to that wonderful expertise I was just referring to. We partnered with incredible institutions, some of whom may actually be on this call today. But we understood that by changing diagnosis and treatment through expert opinions, which we did nearly 2/3 of the time, that was great, but to think comprehensively about the problem, we need to be way further upstream. And we expanded our business to navigate patients, not just when there was a complex diagnosis or a concerning set of symptoms, but at the point of initial care, where they were thinking about primary care, where they were thinking about urgent care, where they were thinking about just where to start their journey and how they were going to pay for it. In 2021, we transformed again to understand the problem very broadly across primary care, navigation, and into specialty care. And that, of course, as you alluded to, was when we merged with Doctor on Demand. In our view, the top shelf telehealth product, a thriving franchise across primary care, urgent care, and behavioral health. And combined, we've released a product that we call All Included Care. But really, the idea behind this product is the most important thing. the care must be integrated. That is in fact the innovation that we need in the United States now. We have all the tools. Back to my early definition of the problem, it's time to put these things together around the patient to track whether you're achieving the outcome that you set out to track and hold yourself accountable to whatever those outcomes are. And that's where we are at Included Health today. There's a lot that we've done in terms of innovation to make that real. There's a lot we've done to go out and validate our own approach here, but that's been the focus last few years.
Well, let's focus on kind of the expert opinions and care navigation that you talked about, that kind of started this whole thing for you. And this is kind of like a tale as old as time, where people really, they trust their primary care doctor for a lot. They trust them to refer them to the specialties that they need. But there's still like this very hard bridge to gap where it's people don't know where to go to begin with, right? They don't know if they don't have a primary care physician, where do they even start? If they do get a specialty physician, can they be assured that that physician is of high quality? So just bring me up to speed on the expert opinions, the kind of the quantitative data that you are able to put around these physicians, and how people are even able to find them. What is it like now? Has it gotten better? Is it kind of stagnated? Fill me in on that part of it.
Yeah, there are at least a few really important concepts that you touched on. And so I'll start where you ended your question, which is, what have we learned about expertise and why does it matter? So it turns out, and this hopefully won't surprise your audience today, but it turns out that, like in every other profession and vocation, there is a real spectrum of technical ability. There's a spectrum of communication ability. There's a spectrum of judgment. And all those things put together go into whether or not that clinician is actually going to be effective for the member. And those of you who have been following our work for a long time know that we have sort of done a ton to write, to research, to publish findings out of our own labs to understand this question of physician quality and patient-physician matching. Because when you look at that sort of expert opinion data that I was talking about, Bob, and you find out that those 2/3 of diagnoses and treatment plans are changing, what you really have to understand is who was behind the original diagnosis and treatment plan, and were they well matched and well suited to the patient in the first place. So we set about to score all practicing physicians in the country. Practically speaking, that actually only means about 96% of physicians, because a number of physicians are practicing exclusively in hospitals or in other settings where it's not appropriate to do this sort of research. But for anybody who's practicing an outpatient, anybody who's doing procedural work, we score using 250 plus now machine learning models of our own development on a daily basis to understand the probability of success given a patient's underlying symptoms and conditions. This is a massive breakthrough. Our belief is that we do have adequate supply of physicians in this country. I know that's probably going to be controversial, but we don't use them properly. Too many of the specialists that we work with and the experts at the AMCs in particular complain that their calendars are full of patients, so they're wall to wall, but it's not patients that they're actually appropriate to their clinical interests and expertise. If you redo the air traffic control so that the right people are treating the right patients at the right time, well, you're going to produce the outcomes that you and I are looking for, and the ones that we're going to talk about today. It's interesting too, when you do that, you actually free up a lot of the care that flows into this specialist too, because by getting it right for the patient the first time, you save that administrative cost, you save the time waste associated with redundant care and redundant care. And so that is one of our major findings in the expert opinion program. And as we branched out into navigation, we were able to apply that not just in those cases of highly complex, but do it at scale for the over 10 million Americans that turn to us for care, through their employers.
So do you think it has gotten both better and easier for a patient to find a primary care physician? I'm sure some people would say no, right? To some degree. I just really want to drill down and understand, like on the basic member or patient level, how confident can they be in finding a physician and being and knowing? I know a lot of different things factor into like the quality scores and everything that you guys do, but how confident can they be that they're finding the physicians they need and that they're of the right quality for whatever care they need?
Yeah. And so I spent just the last minute or two explaining the specialty model of this.
Right.
If you'll indulge me, I just want to actually challenge the premise of whether patients even understand what primary care is and what they would know to be looking for if they're looking. I think for most people, primary care means who is the doctor that I can see fastest and in a, an arrangement that's not going to break my pocketbook. That is what primary care means to most working Americans. And that's okay. At Included Health, we don't sort of try to rewire how people, hold their worldview, because that's going to be ultimately a pretty fruitless journey. Instead, what we're trying to say is whoever that first doctor is, whoever that most accessible and affordable doctor is, they need to be high quality. Because I think behind your question, Bob, is a really important concept here, which is that primary care is that necessary quarterbacking platform. We've used so many analogies over the last decade. Quarterback is one of them. Front door could be another one. But however you're comfortable thinking about it, the primary care doctor and the primary care team need to be capable of figuring out all the steps that the patient needs to pursue. They need to be able to figure it out based on that patient's personal needs. They need to be able to figure it out based on that patient's available insurance networks, where that patient lives, what they will best respond to, and bringing all of that intelligence together in one place and sort of giving that primary care team superpowers is really what we're all about. So I think the direct answer to your question about whether people can confidently find primary care doctors that are high quality is probably no. But do we have the technology and ability today to solve that problem? Yes, I'm super optimistic on that point.
One quick follow-up to that, Owen. You mentioned insurance networks. That's obviously another major part of this. Ultimately, people want to be able to see someone that they know and they like, they trust, but also are they in their insurance? And that's I feel like a completely different problem here. What can be done about that to make sure that the doctors that people want to see are in their insurance networks? Because people don't want to spend that much time digging into that kind of thing.
Of course. And why should they? I don't want to. I doubt you do either. Let's just think about sort of how inane it is, the status quo today. When you see any provider and they are recommending a pharmacy prescription, they're recommending a course of medical therapy like physical therapy, they're recommending a forward referral to a specialist, they don't know whether any of those things are going to be affordable and available to you. Affordable through the lens of, is it going to be a network? And available as in, are those providers even taking new patients? The best you'll get is a sheet of paper with some circled names on it and a strong pat on the back with a good luck. And that's not because those doctors who are providing those pieces of paper don't care. They very much care. There's just no intelligence and backbone to really understand that question. So by combining navigation and virtual care, which is obviously something we care deeply about, you give that team, that primary care team, superpowers. Now they can actually research to see who is the highest quality specialist for this particular situation, right? Because they need to keep in their mind normally 256 board certified subspecialties to even attempt to cover the number of conditions that their patients would normally present with. That's impossible, keeping a Rolodex of 256 names. So we make that part easy for them. And then they can look and see, is this physician accepting new patients? Can we see them in a shorter period of time? Can we go ahead and schedule them through this platform? And what's it going to cost my patients? So what financial advocacy or guidance can I provide up front? That's care the way it should work. That's care the way that we've designed it to work for our members. And I, again, am optimistic that this is going to be a model for broad consumption in the United States. It is going to take provider systems making the investment and saying that they want to enable that sort of member experience.
Let's talk about the providers or the doctors, the nurses who are kind of the front door, right? And the pandemic changed this equation quite a bit by pandemic didn't introduce telehealth, but poured gasoline on it. And you guys have a telehealth platform, so you probably have a whole bunch of data on this, but I'm just trying to understand, utilization I feel like has plateaued and dropped off since the highs of the pandemic. What does it look like at Included? And then, is telehealth, are we reaching a point where just its use in general has been maximized? Are we getting the most out of it?
Well, I read the same studies that you do, and so I can see the national data, and presumably many people who are tuning into this webinar can also see that data. But I have a slightly different twist on all of this, which is that we are operating right now at pandemic highs across all of our virtual service lines, and we have been for the last few months. And so there has been sort of this refrain of, well, we used telehealth during the pandemic because it was the only thing we could do, and then it sort of come back down. And perhaps nationally that's true, although I would probably challenge it a little bit. I think it's highly dependent on whether you're looking at some of the sort of visit data sets that come through claims to make that determination, and you and I can come back on that. But speaking as one of the largest, video-based and telephonic telehealth platforms in the country, what I can tell you is that we're seeing incredible utilization, although it's shifted, and I think it's shifted in an important and actually really positive way. So if during the sort of heart of those COVID, fueled months, it was really very transactional. It was, I need to come in, I've got a visit that I need to complete to make sure that I'm safe to go back to work or to my life or deal with a scary set of symptoms. And we were glad to be right there, shoulder to shoulder with people to support that need. Now it's a lot of longitudinal care, right? I want to actually engage in a relationship, whether it's primary care or behavioral health or specialty, that follows me over a period of time and can convert to a real relationship and a real medical protocol that I, as a patient, can rely on. There are some important demographic trends here. If you're under the age of 55, if you're in the higher income brackets, you are more likely to be using telehealth at a higher rate. And I think that's also worthy of some discussion today. But it does feel like we've moved past a place in the United States where telehealth was used, exclusively by first adopters and people who were curious about it or the otherwise very well, to now this is a very central tool to every successful modern care practice.
There's a couple points in there that I will want to get back to, but I also want to talk about whether this is something, telehealth in general, what's it like for the doctors, the nurse practitioners who are delivering, these consults. I imagine that, there is some element of bouncing back and forth between virtual and non-virtual. Is there even an element of burnout with telehealth if utilization is as high as you're seeing?
Yeah. Maybe like Zoom finger clicking between virtual windows. I'm kidding. I don't hear that, but I will tell you that we spend a lot of time thinking about engagement and retention. And there are some clearly obvious reasons why 120,000 roughly physicians have quit the delivery of care since 2019. Most national estimates I've seen have that number increasing steadily over the next few years. So as we try to recruit and retain the top people in their field, and I can tell you a little bit about what those people look like, it's really important to us that we are not reproducing the harms and the draggy parts of a traditional care experience. And the good news is we know what those things are. We know that it's been the billing, the EHR, the lack of system support, the fragmentation in system, the less time on patient care, the more time on administrative. The data has been clear in every survey I've looked at that those are the reasons why people are leaving the profession. So whether it's how we design our technology, which puts the patient right in the middle of the EHR with the surrounding components like this, so just like I'm doing with you, they can look right into the eyes of the person that they're talking to, or it's easy, flat billing about what we're providing care for. We're not interested in doing a whole bunch of adjustment and creating new codes to maximize yield on our patient visits. We're very confident that as we do the right things for our members, the commercial arrangements we're striking on the back end will make this a successful and high growth company. So it's big things and small things that we've paid attention to support the experience of the providers. Not to mention the fact that the modality alone lets a whole bunch of people who might otherwise have said this lifestyle doesn't work for me come in and support it. One example of this is 60% of our providers today are parents. So they're taking care of somebody else, possibly another adult in the house, and possibly a child. They're taking care of somebody else in the home. And that's pretty incredible, and just shows you that the lifestyle and virtual care is more supportive of where I think providers are telling us they want to spend the time.
We have a question from the audience, and it's a good baseline level one, where it's just, what is the evidence about the effectiveness of telehealth consults? Because this goes back to the age-old question where Medicare and the Congressional Budget Office, they've been wrangling over this for, I feel like, a decade, where it's like, is this helpful, or is it just going to lead to another way for people to bill, and then people still want the in-person consult anyway? So what is the effectiveness of telehealth consults that you're aware of?
Yeah, it's a big question, and thanks to whoever asked it. I say big because I'm going to give you sort of some overflight answer here that explains how the macro studies have come out. But the reality is you actually have to go a little bit condition by condition and service line by service line to understand the real truth in this. But whether it's the U.S. Preventative Task Force, who concluded that 80% of care in a primary or preventative visit could be handled effectively at the same level of quality or better through virtual. So that question has been studied. The question of whether, and this was a recent Mayo study, whether telehealth required additional follow-up because the patient determined that they needed extra care, or that the provider wasn't able to surface what was required for the patient in that visit. There too, it was over 75% of those visits did not require additional follow-up, and very few, I forget the exact number, single digits, required an in-person visit as part of the follow-up. So that's sort of the macro way of thinking about the evidence basis here. I think the reality is there's nuance in these things. If you are dealing with a specialty where, let's just pick cardiology as an example, where you're monitoring blood pressure or cholesterol or hyperlipidemia or any number of common conditions in this country, it is highly likely that the first visit and possibly one visit per year needs to happen with the member in an in-person setting. And that's actually what patients want. And Bob, we should probably come back to that. But the longitudinal relationship is actually preferred virtually, both by provider and patient. There's fewer cancellations of those appointments. It's a more affordable and scalable medium. You don't need people in the same geography to make it work. So it turns out that the so-called hybrid care that people have been talking about, the ability to have in-person touch plus longitudinal virtual connectivity, that definitely seems like the winning recipe right now.
There's another audience question. A lot of questions about telehealth in general. I think we struck a chord here, Owen. I think people just want to know more about how this dynamic is changing, has changed for the better, and what are the ways that we can parse out? And thanks for referencing those studies too. But what are the ways that we can parse out the actual legitimate telehealth encounters that could also maybe just be phone calls? I have a follow-up to this eventually, but how are we able to discern the real valuable ones from the ones that could just be like a quick phone call to your doctor's office, and an NP picks up and says, "Hey, how about you just come in?" What are the ways we can discern between the two?
You need to tell me more about this. So if the patient calls the office and says, I feel like I have sinus related pain and can I see the doctor today? Is that what you mean? Yeah,
exactly. Like what doing that instead of like scheduling a 30-minute Zoom and saying, like, is that the right use of the medium then?
I mean, for sure in that example. So let's just like break that one down, because the telehealth visit is going to cost the member $0 or a tiny copay. It's going to be scheduled from the comfort of their own home. They're going to get, of the 30-minute visit time, they're going to get 20 to 25 minutes of the provider's time. And it's going to happen on time. And they're not going to run the risk of actually getting sick or by sitting next to somebody in the waiting room. Compare and contrast the standard visit. So that same encounter to get the same information on the table about what's required, including, prescription of an antibiotic, let's say, is going to cost 2 to 3 times as much. This is a safe rule across the country. It is probably not going to happen by sort of averages on time. And about 10 minutes, if they're lucky, of the scheduled visit time, the provider will actually be in the room. So sort of objectively, that is a worse experience. Now, where the sort of determination gets more complex is when you have sort of things that need to be studied physically. So just to use a equally common example, if the patient has strep-like symptoms, well, today, unfortunately, there's no really good at-home strep test. And so you need to go somewhere where you can have that physical experience. And I'm excited because a lot of the infrastructure is actually growing up to support an equally patient-friendly and fast and scalably affordable approach getting that sort of data done as well. So hopefully that's responsive to how people were thinking about it.
Yeah. And I want to go back to something else that you said too, when we first started talking about this, in that if you are more affluent and you have a more flexible job, obviously telehealth is a much more feasible outcome for you. But how do we make telehealth more accessible for someone who works a more rigid work schedule? They can't just pull up their iPhone or go hop on a laptop. That seems like an obvious barrier that is like quintessential US healthcare, where it kind of separates those who have more flexibility versus those who don't, or can tie in income there as well.
Yeah. This is an area, as you know, because you and I have known each other for a long time, that I'm super passionate about. And I'm passionate about it because we've got a sort of deeply broken system in terms of the equity part of the quadruple aim. And it's totally fixable again through technology. So I'm going to sort of explain to you, at least in our view, how we see the prescription. But I also want to just use a second here to challenge a little bit about some of the telehealth specific questions, because I think we all want to move forward on this. If we were to sort of preserve our conversation today, Bob, and look back at it in 5 to 10 years, maybe 3 to 5 years, the fact that we're sort of creating a boundary condition between telehealth and in-person care, we will seem very old-fashioned for having done that. Similar to the way that when we made the move to digital banking and we didn't use branches as much or at all, we don't really think about banking as digital banking anymore. We don't really go on and sort of look for telebanking and think about that. That's a different and differentiated experience. If anything, actually, the old banking experience might look a little bit antiquated. Nor, by the way, in that analogy, did we try to reinvent all of the same things that we had in the old-fashioned experience. For those of us who are old enough on this call to remember, we used to go in and meet with somebody at the bank to get cash out, and they would be on the other side of sometimes a glass or a barred window for their safety. It was sort of weird experience, and we had to do a bunch of paperwork.
It was wholesome, and it was a wholesome event, wasn't it?
Yeah, so wholesome. And so that we've sort of moved past that in a way that we haven't really stopped to reconsider. And I feel like we're at that transition point in how we're thinking about care. Just so you know where I am, this is just all care. This is the future state of healthcare, and it's one that is more equitable, more accessible, more affordable, where we don't have to compromise around geography. Now back to your question, because I do think it was a good one. We support many of the largest retail working populations, food manufacturing populations, other populations that have shift-based work or inability to just sort of tune out or step out of the room, as you and I might be able to do, to take a visit. So it's been very important for us philosophically and morally, frankly, that we operate a 24/7 service. And there too, I think it's really important. Like, you don't need to be able to pay for parking to be able to get care for us. You don't need to be able to find childcare to get care from us. You don't need to be able to take time off from your job, frankly, to get care from us. And what we see is sort of a wonderful opening up for many of those populations that are most in need to find primary care. I want to just give you a couple really, really cool stats. So 41% in our all-included care product, 41% of members that were using primary care through us had not seen a primary care doctor in the last 2 years. And the biggest single reason why that had been the case was access. Back to your question about, can they access primary care? With our primary care practice, you're getting access to a visit same day, next day, or in 2 days. Average waiting time to see a new primary care relationship in the United States, establish new care, is over 50 days. By the way, the same thing in behavioral health, which is, of course, as you know, another one of our service lines. So merely by opening up the spigot on that access to care and making it easy for people to get, to get access to their team through that medium, you've entirely changed the game. There are many, many counties in the United States that don't have a single primary care provider of any credential that are taking new patients. And that is concerning to me. I'm sure it's concerning to you. Just one last stat on this, because I think it's really cool. When we look at the behavioral health specific application of all of this, so 25% of members who have sought and found behavioral health treatment have had a reduction of depression and anxiety related needs in the first month. But when we cut that deeper to the people who have not had a previous behavioral health encounter and are starting for the first time with us, we found that 35% of those folks live in predominantly Black and Hispanic zip codes. And so that's a really interesting finding here too, that by democratizing and opening up access in this way, we can think about that health equity question a little bit differently.
Just want to give a quick thanks to people who are sending in questions. I'm trying to keep track of them all. There is another related question here, Owen. How best can telehealth work for, people who either have no technology or low technology or don't want to, as this guest asked, limited minutes to blow through telehealth? Is there old-fashioned phone care? Like what are the solutions for people who aren't in the same situations, for people who just have an iPhone or a laptop to just throw it open? What's the best way for those folks?
Yeah. Terrific. I do think that when we look at the expansion of telehealth across this country, a lot of it has to do with the availability of broadband and how accessible that is, and sort of how those costs move down proportionate or just, on an inverse relationship to the overall use of telehealth. Interesting and possibly not totally surprising finding in our book is that frequently people are using public Wi-Fi. So they're not actually chewing through minutes. They might, quite frankly, be in a Starbucks or be in a McDonald's or be at their local library taking that visit, which is fine. It's great. And I think that those organizations, McDonald's is a client of ours as well. Those organizations, embrace, their relationship with the public good and their relationship and opportunity to be an infrastructure provider. But it's a good question because I think we want to make this equally accessible. We've created barriers around parking, around sort of these artificial hours when care services were available. We don't want to create those barriers around what can be a really emerging and important technology.
Owen, I want to ask you about something. It's all related, but to me, it's a classic example of tech actually making a gigantic problem. And this is on the kind of the payment financial side. And I know you and I had talked before about this issue of physicians responding to emails, the my charts, and then patients are getting billed later. Curious what your response to those types of practices are, because I don't think people really expect kind of like the very lawyerly practice of getting a billable statement for an email. So I'm curious what you think about that. That was obviously a big issue, a summer or two ago when more health systems started to do that.
Yeah, I wrote down my answer. Can you see that? I find it disrespectful. I find it cynical. I understand the underlying need for provider systems to get paid appropriately for their care. I really do. And primary care physicians in particular, I think have taken it on the chin over the last few years. I'm hopeful too on this point that overall compensation is going to increase for primary care. But at this particular moment, we're at least a local low, if not an all-time low relative to their peers and how they're getting compensated. So I definitely believe that people need to be compensated, but I think we erode trust with our patients when we pull shenanigans like this. New York Times had obviously a great story about a health system in the Pacific Northwest that had sort of broken trust with their members associated with revenue cycle management practices that were pretty aggressive. This is not exactly like that, but I think it's in the same vein. That if you think you're going to a place to get care and you think that care provider has your best interest in heart, well, you have to actually make sure that you deliver all the way through on the financial agreement on it. Most people in the United States understand that we do need to pay a little bit for our own care and we need to be responsible for our own care. I think we do understand that, but we don't want to be nickeled and dimed, and we really don't want to be surprised. And so, I think the antidote to this, by the way, is to create agreements with health insurance plans, with companies like mine, with others, to have sort of an all-in bundle or for care, for services, so that you can provide it directly and not have to come back to the patient on something surprising.
Well, as more primary care physicians in particular get gobbled up by hospital systems, for example, it's ultimately up to the parent company, whether it's a hospital, a bigger chain of physician clinics, And I imagine they're going to want some kind of ROI. Like I get to your point. I understand, physicians don't want to be sitting at their desks answering emails all day and feeling like that's their job and they're not getting paid for it. But at the same time, if if they have a different owner and they're saying, hey, bill for these things, they're kind of put in a tough spot then. So is this, I'm just trying to think through what are the available options, because ultimately someone's going to want to get paid for some kind of work. It's the nature of the US healthcare system.
That is the nature of the health system we have today. It does not need to be the nature of the health system we have tomorrow. We can pay for healthcare outcomes, and we can understand that we should be paid generously to produce healthcare outcomes. And then we do the things that are necessary to support those healthcare outcomes in that order. Atomizing down our fee-for-service structure to the number of messages and ultimately the number of words we're sending to our patient is absolutely the wrong direction. And I think we can do better. I think we must do better for ourselves as patients and for ourselves as providers and the teams that are trying to provide care, because nobody really likes that. I do have concern. I don't know if this is quite what you meant when you said ROI, but I do have a concern that when many of the sort of largest medical platforms in the country, the EHRs in particular, are really in the business of conducting billing activities, that the ROI to show to their customers, so the health systems that are buying those EHRs, that the ROI is that how do you get sort of more dollars per minute of usage of the EHR? That totally gets away from the idea behind an EHR in the first place, that we would have a safe, accessible, intelligent store for medical information. We've way missed on that, I think, in this country, but I think we can correct.
And a quick follow-up to what we were talking about with the telehealth and people being able to use public Wi-Fi. Are there privacy concerns if someone is in a public setting using public Wi-Fi? HIPAA related or otherwise, about kind of conducting a video visit like that?
Yeah, you have to, it's a good question. You have to have two-way, so in terms of the transmission of the data itself, no, because, at least our site, and I would assume that everybody else requires, SSL, two-way encryption, 256. But in terms of the being in the public setting and the communication, yeah, the patient needs to take some precaution to be careful about how they're communicating with the provider. And it's a good question. It's a question and concern that actually can occur in the home or any other place too. So it's a good thing to be mindful of, and one of the things that our providers want to talk to members about when they're engaging with them for the first time.
A big picture question here is very topical and newsy. We've seen a lot of large conglomerates. You think of Walmart, CVS, United Health. They are very much your primary care doctor now. United Health, I think, is actually the largest employer of doctors writ large, and possibly just primary care in particular. Kind of curious how these large companies will change primary care. What are their strategies? Optimistic, less optimistic? What are your thoughts on kind of how all these different companies are going all in there?
Pretty optimistic, honestly. So it's interesting. The whole sort of conceit behind our discussion today, Bob, was sort of can tech save primary care? I think the good news, we didn't quite baseline it for folks. The good news is the state of overall primary care, at least as it relates to our investments in primary care, is strong. We're sort of getting back to an understanding that, the 2-to-1, 3-to-1, 4-to-1 specialist to primary care ratio that we've had in this country for the last couple of decades is out of whack and overly focuses on a sick care form of healthcare versus a healthcare form of healthcare. And so I'm excited about a bunch of new entrants. Whether any one of those models is going to be ultimately the perfect solution, I'm not sure. And I think it's going to take us a few years to figure it out. But if we can create a really easy and affordable and scalable and recognizable way for members to get access to primary and preventative care, we should all be super excited about that.
Okay. Lots of other questions coming in, Owen. a lot of primary care in the US is oriented toward a physician model. In other countries, it's community health workers and other types of clinicians. And I would even say here in the US, it's actually we're encouraging more nurse practitioners, APPs. But this person's asking what possibilities exist beyond telehealth provided by providers or APPs. Is community pharmacy an example for more digital care? What are your thoughts on that?
Yeah, I love this question. And it's true. The rest of the world is way ahead of us on this topic. I think there are a couple of things that are happening now that people can get pretty excited about. One is, you can use non-clinical or minimally clinically trained forms of advocates, coordinators, concierges to do a lot of this work empathetically and intelligently to get people around care, because the navigation part is so challenging and when done properly is so predictive of good outcomes. So I'm seeing a lot of hiring there and a lot of tooling up and scaling in that workforce, which I think we can all be really excited about. In the home-based space, it's also really cool because you can have a tech of a variety of sort of training types go into the home and work with a virtualist to the convenience of the member, to the time efficiency of the provider and the member, seemingly with equally good outcomes. I'm excited to study that longer term. We've been doing it in the Medicare population longer than we've been doing it in the commercial population, but I'm pretty optimistic there as well. And then I think generally there's a lot of, sort of one-to-many support groupy type setups that are particularly effective for things like behavioral health, substance abuse, diseases that are metabolic in nature, where by getting patients together with a facilitator and some medical guidance, you actually get really interesting outcomes, and you have sort of inbuilt support and coaching as part of that. So there too is an innovation that I'm really excited about. A lot of that stuff is coming and hardening right now in a way that can be available to more people and more communities.
We've talked a lot about this is like from the clinical side, but I also want to know more about the employer side. A vast majority of people get their health insurance. I shouldn't say majority, I think a plurality. Either way, a large chunk of people get their insurance through their employer. And what are we seeing here? In the past, we'd seen employers, for example, putting up on-site health clinics. Those fail to certain degrees. I feel like there's a little bit of a comeback there, but just talk a little bit more about what employers are doing, what they're demanding in terms of primary care for their workers. How are they getting involved in this?
Yeah. Great question. 150 million people in the United States get their care from their employer or from a family member's employer. So that's how they get their coverage. That is indeed the plurality and narrowly misses being the majority. And that number is likely to grow as more people live longer lives, stay in the workforce longer. And yet, so much of the innovation that we've talked about the last few years in healthcare has been in the exclusive domain of Medicare Advantage, managed Medicaid. And that's a shame, because if we're serious about primary care and preventative care, the most effective deployment of that tool is way earlier in people's life, not frankly when they're in their aging and more complex years. I'm not going to say that it's not important there. Of course it is. But if you want to avoid diseases of that are cardiovascular in nature, that are neurodegenerative in nature, that are metabolic in nature, then those are the things that you can invest a lot in while people are in their working years. Employers, what they're telling us, recognizing the same data that I'm just describing, is that they're fed up and they're out of answers, really. They're both fed up and out of answers on what is coming at them. So let me sort of paint the picture for you. Double-digit increases in trend. That's the overall inflationary rise of their healthcare cost exposure. Most national actuarial firms are now forecasting between 10 and 15% and can be higher for some of the smallest groups in the country. This at a time when other inflation already is threatening their business on the cost of the goods that they produce. The HR teams that are tasked with supporting and making decisions on the healthcare benefits are getting smaller, so fewer sort of people to make the big decisions on those benefits. and the dollars associated with supporting those benefits are also going down. So it's a bad mix of solutions. And there's been a lot of venture capital. There's been a lot of money going into digital innovation that theoretically is designed for this marketplace. And yet it's hard. It has been hard to figure out how to separate the wheat from the chaff. So they're now looking to consolidate. They're looking for platforms that can do more than one thing for them. So the so-called point solutions that solve a narrow clinical problem, I think, are going to be stressed out in the next few years because they're going to find it very hard to capture the time and attention of the employer that's saying, we want to put all of these things together on one platform. The good news, though, is that those platforms are capable of producing cost results and clinical outcome results that are really terrific. And as investments goes into those platforms, then I think what you're going to see is an approach to preventative and primary care in the commercial space that's super compelling. I am heartened by the fact that, when I look at our over 300 plus clients, most of them are talking about primary care if they're not doing it with us already today. That's a huge step forward. Now, a lot of them talk about primary care differently, and they may have a different definition for it, but they're recognizing that that is one of those key planks in the overall platform.
Want to go back quickly, Owen. We're getting more questions here. Going back to this idea of other entrants getting into primary care, the Uniteds, the CVSs, those. What are the consequences? I think this is a fair question. What are the consequences of these entrants controlling referrals for things like surgeries, total hip replacements, those types of things? Because they obviously play the role as both insurer and provider in those cases.
Right. So I think that to whoever asked, I think the concern is well founded, or at least by design, you would think that there would be an incentive to do something other than what is super high quality. The reality is that most of those companies are just now trying to figure out how to even design their referral logic. Obviously, one of them is now part of a very large insurance company, or coordinated with one of the large insurance companies. And Bob, you mentioned another large insurance company that has a stake in all of this. I think that you will see a logic that's inbuilt around using those networks versus selecting for quality. And I hope and expect that people will sort of make decisions based on where they enroll with those questions in mind. In our view, the whole reason we built our quality matching program was not to have our own proprietary network that had its own discount structure attached to it, but instead to just illuminate for people what high quality looked like. Because when you get to high quality medicine and surgery, you get better faster. And when you get better faster, you cost the system in aggregate a lot less money. So we're hopeful of the model that we have developed. Some of those companies are partners of ours. We're hopeful that we're going to use the technology that we've built for their referrals, but it is a space to watch for sure.
We're going to try to squeeze in two more questions before we end it, Owen. Just going back to telehealth real quick. I think you might have addressed this a little bit. But what is the adoption of telehealth? What does it look like within minority communities, Hispanic, Asian, Black populations? And is this a way that health equity could be expanded within those underserved populations?
For sure. I don't know the exact numbers overall in terms of absolute penetration. We were just talking earlier a little bit about use in our company for first-time behavioral health visits and for primary care visits. One of the things that we have built as part of our solution is the ability to pick your provider. So when you ask different communities, so whether it's the Black community or you ask the LGBTQ plus community, often one of the things you hear is that the majority of respondents surveyed from those communities will say that they have avoided care because of the feeling of being discriminated against in a prior episode of care. That's not a good formula for long-term healthcare outcomes. So we've designed our care delivery to be of great service and reflective of those communities. So 25% of our physician and clinician panel identify as Black, Indigenous, people of color. Over 10% identify as LGBTQ plus. We do credentialing and training for those providers to better support those communities. So that to us is really important, because it turns out that when I or anybody can work with a provider that I think is going to understand me, that might know something about my community, but know something about my experience, the likelihood that I will stick and trust with that provider much higher, and therefore the outcome's much better.
Final question, and I hear this a lot from, in particular, health insurance brokers. It's pretty, I would maybe say, low tech, but this idea of direct primary care, or this paying a certain amount and you kind of get all the primary care. It's like the primary care buffet model. What are your thoughts on direct primary care? I feel like a lot of employers have embraced it in terms of like making it like a top option for employees, covering the cost of that type of thing. Where have you seen that going in recent years?
Yeah. So that's one of the variants. When I told you that most of our employer clients are talking about primary care in some way, that is absolutely one of the variants. And I love it, because oftentimes what comes with direct primary care is a higher rate of reimbursement for just doing great, inclusive, longitudinal, comprehensive primary care. It faces challenge on scale, because often those direct primary care practices do not have the telehealth capabilities, the navigation capabilities, the integrated behavioral health capabilities, and the other things that companies like mine are able to do to surround that patient. So it seems to work best for a small company that may have a few hundred employees in a town, where they can make best use of a primary care doctor or two in that town. But in terms of a national model, when you work with, the large employers in the country, which we do, what they're looking for is something that is a model that's national in scale, with the ability to do that local integration at a deep level, to make sure that as people move between virtual and in person, that they can feel that it is a connected and seamless experience.
We're going to keep it there. We're just about out of time. A big thanks again to Owen for joining me today. Really enjoyed this, and appreciate all of you submitting questions throughout. Thanks to our event sponsor Nuance, and take all of you guys out there for taking the time to join us. STAT's upcoming Breakthrough Science Summit will be taking place May 3rd and 4th in San Francisco, and virtually. You can join us to see where medicine, biology, and technology converge. More information on that can be found on our website. But a big thanks again to Owen and everyone else